Sorry, we don't have a device to get our seating right. Good morning. I'm Carol Hahn. I'm a radiation oncologist at Duke. And thank you so much for the organizers for the opportunity to speak with you all today. Our first session here is looking at advanced technologies in radiotherapy. And as those of you who may not be involved in our field may not be aware, radiotherapy is a local regional therapy for cancer. It's used in about 50% of patients with cancer, and we use it for both curative and palliative applications. In our session today, we're going to look a little bit about the science behind radiotherapy and get a little bit of a primer on what are these terms. You hear a lot of terms about what are we speaking about when we talk about things like IMRT and IGRT and protons and photons. And our speakers will elucidate a bit about that. We're going to look at the clinical benefits because the technology is advancing, which can be a good thing for our patients. What are these benefits? Then we are going to look at comparative effectiveness research in terms of how do we demonstrate, as Tina's told us, there's a fast uptake of this technology, but how do we step back and look at who benefits and who may not get a benefit in terms of thinking responsibly about costs and control. So our first speaker, we have three speakers today. Dr. Stephen Chmura. He is from the University of Chicago, and he is an associate professor in radiation oncology. He oversees the breast cancer and CNS cancer programs. And Dr. Chmura will be speaking to us about the science behind photon therapies and their intended use.
So we advance it here. Got it. It is an absolute pleasure to be here today, and I really hope that this presentation isn't just informative, but that it can spark some questions and interest for the following sessions. So over the next actually 21 minutes, I'm really going to talk about the evolution of photon therapy from 2D planning to this intensity modulated to image-guided irradiation therapy. I'm going to show you what actually little evidence exists that we can actually improve patient outcomes, which has mainly been focused on the reduction of using a technology to reduce complications. And then finally, I'm going to give kind of an example, which is pretty exciting, which is using this new technology to treat a group of patients, namely metastatic breast cancer patients who have very limited spread of disease, who we couldn't otherwise treat, and to really see, can we change overall survival in this population? So over the past century, we have known from the first x-rays that were taken to the very first patients who were treated, that our ability to treat tumors and to actually ablate them was really limited by our ability to both penetrate deep inside of the body and to actually avoid normal tissue toxicity. So the very first tumors treated and cured were things like cervical cancer, where it was easy to access, or even skin cancer in the late 1800s. Again, going all the way back, these sites were easy to access close to the surface and then able to avoid normal tissue toxicity by simple proximity. As technology advanced, we were able to throw our beams further inside of the body, but unfortunately, we usually ended up treating more normal tissue to a higher dose than the actual tumors, by greatly limiting our ability to cure them. So going all the way back to the 1960s and 70s, Dr. Hellman and others at Harvard actually hypothesized at one day, when we had the computational power and the hardware and the software, we could use computer control to actually use multiple beams from multiple angles to really add up into our target tissue and avoid normal tissue. And this is really what this evolution from 2D planning to intensity modulation to image guidance really means. So just so all of us are on the same page here, this is sort of a modern linear accelerator. This is actually from our place, so it's not that modern. But again, though, if this pointer works, I don't think it does yet. So basically all of the beams come out of this head of this half-ton gantry here. This spins around the patient, which is located on this table here, and this table is able to shift and move to provide many degrees of freedom. And to actually shape that beam, we use something called a multi-leaf collimator, which is composed of hundreds of leaves like that can be controlled by a computer, as Dr. Hellman had suggested. And these can actually move like while the beam is turned on. So then when you talk about the evolution of like 2D into 3D planning, what we really mean is that by using this shape to actually shape a potentially one or two beams that would treat through and through the body, giving like some like customization to a tumor shape, but still really giving about the same dose to the surrounding normal tissue as to the tumor. But with 3D planning, we actually talk about entering a 3D volume, both of the target tissue and of the surrounding organs, or the organs at risk, OAR structures, so that it can try and give a higher dose to the targets and a lower dose to the surrounding tissue. So if we look at a case of pancreatic cancer where the tumor is in red and the spinal cord is in blue and the kidneys are in green here, if we treat using kind of a conventional 3D technique, the beam is either all on or all off. So in black here is at the beam coming in from a certain angle, say at 0 degrees, is all on. With intensity modulated, we use a computer to control those leaves in that multi-leaf collimator to move in real time as the beam is on, to help shape that beam and paint the high dose into the tumor and avoid the actual kidney structure. So really, IMRT has really to a revolution in our ability to treat cancers. And then it has mainly been to a reduced dose to normal tissue. So in the brain, it is to reduce a dose to the optic chiasm and the pituitary structures. In prostate cancer, to a reduced dose to the rectum. In gynecologic cancers, to a reduced dose to small bowel and to bone marrow, when combining chemotherapy. And in head and neck cancer, to reduced dose to the parotid gland and then other essential swallowing structures to really improve quality of life. And we have now taken this idea of intensity modulated radiation therapy even further, and even more expensive is the idea of variable arc radiotherapy, or VMAT, or rapid arc, where instead of having 8 or 9 fixed angles of that large half-ton gantry, that whole gantry can now rotate at varying speeds controlled by a computer while the beam is turned on, further creating a more conformal shape for our tumor. When we talk about radiosurgery, it is the same idea. It is using multiple beams from multiple angles, hundreds of small beams, all coming in, colliding at a single point to treat a brain metastases or a brain primary tumor in 1 to 3 fractions, giving a very high dose to the tumor and a very low dose to the adjacent surrounding brain. And we have now extended this even further, the idea of doing radiosurgery, and not just on the brain, but throughout the body, into places which are hard to get to by a traditional surgery, albeit in lung or the liver or the lymph nodes. Again, having extremely high ablative doses with control rates as good as, if not superior to, a conventional surgery. So I think one caution, though, is that as we have improved our hardware and software, and we have made the shape of our beams quite sharper, what we have to take into account is the idea of imaging and organ motion. And I think that this can be best seen here, if this plays. Oh, they promised me this would play. I'm sorry. So if you imagine that this patient is breathing, this tumor, which is outlined here statically on 3D, this is going to move up and down outside of the field. So if you think about when we treated in the more conventional 2D era, that if you had a very large square field treating, you would probably hit this tumor because it would be moving inside of it. However, now that you can conform is dosed so appropriately, how do we account for the fact I got this patient is um, alive, like breathing and like moving? So there are various ways of doing it, from inexpensive to quite expensive. The first way is to actually control a respiratory motion by simple compression shown here. This works actually fairly well. It's fairly uncomfortable, but again, it can greatly reduce tumor motion, allowing us to treat less normal lung. You can also use optical guidance, actually watching somebody breathe and like making the actual basic assumption that the external movement of the patient's chest cavity is going to be related to the tumor, which is true some of the time and is probably far superior than not using it. We can also now use image guidance prior to turning on the beam and then actually do a CT scan on our treatment machine to make sure that every single day in 3 dimensions that our tumor is inside of our treatment field. Again, though, this is only at time 0, not throughout the course of treatment. So the ultimate evolution of this treatment is to use things like robotics, where you can track the tumor in real time, move the beam, and continue to treat. So in terms of a quick summary of this evolving photon technology, that there has been a true evolution from large two-dimensional fields treating through and through the body to 3D conformal shapes. To treat this way, it really requires a precise knowledge of the anatomy and of the tumor and organs, and that, again, as we increase the conformality and like our ability to shape these beams, it really requires us to use good imaging to make sure that we can hit the target. So like, what is some of the evidence for improved outcomes? Well, it comes from a single institution series. It comes from some few pieces of level 1 evidence. And also 2, I don't think that you always need a randomized trial if it's absolutely clear. So in terms of IMRT and intensity modulated literature, or then almost any new technology, the literature is filled comparing dosimetrically that the new technology is always going to be superior at decreasing dose to the normal structures compared to the older technology. However, how does this actually translate? Well, going all the way back about 15 years ago in like single institution series, it was actually fairly easy to show when treating gynecologic cancers a reduction in terms of like bowel toxicity with IMRT compared to more a conventional 3D. This also translated to bone marrow toxicity, especially when combined with chemotherapy in cervical cancer. This was pretty clear, this was pretty dramatic, and prior to any kind of true like randomized trials. In terms of level 1 evidence, it really comes from like breast cancer and head and neck cancer. Canada conducted a randomized trial of like IMRT breast cancer, shown here on the left, compared to the conventional two-dimensional treatment on the right, at the endpoint being acute like skin toxicity. And I think it's clear, if you look at this blue line, that at about 5 weeks after the start of treatment, that the conventional arm has a significantly higher rates of grade 3 or higher toxicity compared to the IMRT arm. So actually conforming this dose to the patient and like reducing excess dose inside of the tissue actually affected acute toxicity in the randomized setting. The UK conducted a similar study, but also showed that at long-term follow-up, it greatly improved objective measures of both cosmesis and of induration and like pain, showing that a true reduction of acute side effects from radiation therapy in these women lead to improved long-term outcomes. Interestingly, it's almost impossible to get a payer to pay for IMRT, even though you have such robust level like 1 evidence. If we kind of look at the head and neck data, this is probably the most cited trial. It's the RSPOR trial, again out of the UK, where they look at the incidence of xerostomia, or dry mouth. And over time, over the course of 12 months all the way up to 24 months, the patients treated using IMRT at being able to spare the parotid glands have a significant reduction and then actually improvement in their swallowing function and quality of life. So I don't know if we always need a randomized trial for everything if the outcome is clear. If we look at endocrine dysfunction in children in terms of growth hormone deficiency on the hypothalamic axis, we know that at doses of 10 gray and under, there is very little effect in terms of the long-term reduction in the function. But as you increase at that dose, it becomes quite dramatic. Again, I don't think with good single institution results like this, that the dose to the hypothalamus needs to have level 1 evidence. And I would argue it's the same thing for the cochlear dose and combined with cisplatin in children. We know that by reducing the dose by half is going to significantly decrease the severe hearing loss seen in children. So I think what's really interesting is that up until now then, the evolution has really been about using this new technology to decrease dose to the normal tissue and improve complications. I think what's really exciting is we are now at the point of saying, can we use this technology to treat a group of patients who we couldn't really treat before, and to say, can we alter the actual natural history of a disease? And I'm going to use oligometastatic breast cancer as an example. So I think, and people think about metastatic disease, people always think about it more on the left, where it presents as being widely disseminated throughout the whole body. But in a few patients, that they can present a quite limited disease in 1, 2, 3 spots. And it's really interesting that Dr. Hellman and Dr. Exelbaum actually noted now almost 20 years ago, at when patients present like this, that they probably only progress quite slowly and probably only to a few new sites. So if that's true, they hypothesized that some kind of local intervention could potentially lead to cure. So, and this was not without some robust data from the surgical literature. So if we look at breast cancer patients who had limited disease to the lung who could be operated on, it shows at those who had few metastases could in fact have long-term survival if in fact they are surgically removed. And the same thing was also noted in patients who had metastases to the liver. So then now that it can use stereotactic body radiation therapy, it can treat literally throughout the entire body, and you have outcome data from single institutions showing that you can control these mets you treat 80 to 90% of the time, which is probably equal to, again, if not superior to surgical resection. This has obviously created quite excitement in terms of the people who treat with radiation therapy. And so if we do a quick search of PubMed, in 1995, the idea of doing this was not really published quite much. In 2005, it was a few more things. In 2007, when I first suggested to the NCI that we conduct a robust randomized trials to actually see if in fact this is going to lead to improved overall survival, the actual number of publications has now skyrocketed. And those clinical trials were activated actually at the end of 2014. If we look at a survey of over 1,000 radiation oncologists throughout the world, you can see this adoption. And I think that this is a trend which is going to be seen throughout this whole conference, that before 1995, almost nobody was using this technology, and now this is almost universally done in the absence of any good level 1 evidence. So on the good news is that the first randomized trial has now opened on December 24th. It is taking women with breast cancer who have 1 to 2 metastases, and they will be randomized to arm 1, which is standard of care, or arm 2, which is to treat and to ablate all known sites of metastases. So what I think all of us would hope after spending all of this money on this large 400-patient randomized trial is that if ablative therapy improves overall survival, it should lead to a true paradigm shift into a true multidisciplinary treatment of these women who have this limited metastatic disease. And I would also hope on the converse is that if it does not show an advantage in terms of overall survival, then off-protocol use of SBRT, which is now so widespread, should really stop. But I think this is the point of a discussion, because while I hope this would happen, it's not going to happen. And the reason is that if this trial is negative, how we design trials, we won't know why. Because really, it is really going to be one of 2 reasons. One is that the hypothesis should be rejected, that the ablation of these metastases is not going to affect overall survival. But what could also happen is that we could have poor use of the technology thrown into the community and simply get a type 1 error. And I guarantee people are going to argue the latter. So I think also in terms of a discussion, when we are designing trials using these new technologies to see, can we treat populations that would normally not be accessible, or to ask these really interesting questions, I think that we have to ask, how do we want these trials designed? Do we want it designed to ask, is our new technology X, is it really rigorous enough to be thrown into the community and used without any quality assurance and to really impact the biology of the disease? But if we actually want to ask, if we use this technology appropriately, if we can hit these targets, if we can ablate these tumors, are we going to change the actual natural history of breast cancer? Then we need to do more robust quality assurance. We need to invest in that part in these clinical trials, which is actually quite inexpensive. And then that's all I have for you today.